So starting with the April 2023 paper 2, the question number 1 was asked about the role of newborn screening. So this question will provide you in the PDF format, okay, by tomorrow. Next question, question number 1B, that was management of a neonate with VDRL positive mother. So you should first be knowing that routine serological testing, talking about the antenatal test, so routine serological testing for syphilis should be undertaken in all pregnant women at first prenatal visit. As we all know what implications syphilis can have in the first trimester in the babies. So during the first prenatal visit only, we'll have to do the routine serological testing for syphilis, and again then repeated at 28 weeks and at delivery in high risk cases. So first prenatal visit, 28 weeks and at delivery. Here, if mother is syphilis positive, that is, if she's having reactive VDRL or RPR and confirmed by reactive TPHA or FTABS. These are the confirmatory tests. What is supposed to be done? You have to evaluate the infant. If mother is VDRL or RPR positive and confirmed by TPHA or FTABS, you have to evaluate the infant. First, you need to assess the adequacy of maternal treatment. Second, you need to do the pathological examination of placenta, or the umbilical cord. Third thing, you need to do the dark field microscopy of suspicious lesion or the body fluid. Fourth is clinical examination of the infant for evidence of syphilis. This can include non-immune hydrops, anemia, jaundice, hepatosplenomegaly, rhinitis, skin rash, and pseudo paralysis. And fifth, quantitative VDRL or RPR on infant serum. So these are the 5 things that is first to be done to evaluate the infant in these 5 points. Next, management is dependent on the scenarios. Scenario 1. Known as proven or highly probable disease. Presence of any one of the following. First, if physical abnormalities are, if there are physical abnormalities suggestive of congenital syphilis. If the next thing is if there is VDRL or RPR titers are 4 times higher than the mother's titer. And the third thing, there is a positive dark field test of body fluids. If any one of them is positive, you consider as a proven or highly probable disease. Now, what is needed to be done? Additional examination, evaluation, additional evaluation. You need to do a CSF and send the samples for VDRL, cells, and proteins. Cells are usually based, proteins are also based. You need to do a CBC, a differential, and platelet count. And other tests as clinically indicated. These includes long bone X-rays and chest X-rays, LFTs, neuroimaging, ophthalmologic imaging, examination, ophthalmologic examination, and BERA. So you have to evaluate in this manner. And talking about the treatment, treatment is penicillin G, 50,000 international units per kg per dose, IV, 12 hourly. This is to be given for first 7 days, followed by 8 hourly for next 3 days. Total duration is 10 days, 12 hourly for first 7 days and followed by 8 hourly for next 3 days. Or you can give a procaine penicillin G 50,000 international units per kg per dose intramuscular in a single daily dose for 10 days. The duration of treatment remains same, 10 days, but single dose intramuscular of procaine penicillin G. These are the two treatment options. Next scenario is also known as possible congenital syphilis. So in the second scenario, there should be presence of all three. One is a normal physical examination. So physical examination should be normal. Second, PDRL or RPR should be less than 4 times of maternal titers. And third, if in mother there is any one of the following. First, mother has not taken any treatment or inadequate treatment, or if there is no documentation of treatment. Second, if mother is treated with erythromycin or any other non-penicillin regimen, non-penicillin G regimen. Third thing, if mother has taken maternal treatment administered less than 4 weeks before delivery. If any of these three conditions are fulfilled and there is a normal physical examination and your VDRL or RPR titers are less than 4 times of maternal titers, you label it as possible congenital syphilis. And what evaluation, additional evaluation, it remains same as scenario 1. Regarding treatment, if any part of infant's evaluation, if any part of infant's evaluation is abnormal or not interpretable,